Hello and welcome to Medical Lectures Encyclopedia. I'm Samir Bhatia and I'm glad you're here. On this channel, I'll be taking you through a comprehensive series of lectures designed to be your one-stop destination for postgraduate medical exam preparation. Whether you're sitting the USMLE, MRCP, FRACP, MRCPH, MRCPI, NEET-PG, or NEET-SS, you'll find structured, high-yield content here to guide you at every step. Each lecture is built to make difficult topics clear, memorable, and exam-ready, combining sound clinical reasoning with the depth these examinations actually demand. So, wherever you are in your journey, subscribe, settle in, and let's master medicine together, one lecture at a time. Over the next hour, we are going to build aortic regurgitation from the ground up. And I do mean build, because AR is fundamentally a plumbing problem. A valve that should slam shut in diastole instead leaves the door open, so blood that was just ejected comes straight back. Everything else, the collapsing pulses, the decrescendo murmur, the enormous heart, the timing of surgery, falls out of that one leak. The spine of this deck is Harrison's, but I've layered on the current ESC and ACCA book guideline numbers so you're exam ready and clinic ready, drawn so you can reuse them on a whiteboard. A quick promise: every joke today smuggles in a fact, so keep your pen moving even when you're smiling. Here is the map for the journey. We move in the same logical order you should think in front of a patient: what the lesion is, why it happens, how it wrecks the ventricle, how we grade it, how it shows up, how we image it, what it can be confused with, and finally what we do about it. The two ideas I most want to survive this lecture are sitting in blocks 3 and 8. Block 3AR is a combined volume and pressure overload, which is why the ventricle eventually gives out. Block 8: the whole art of managing chronic AR is operating after the ventricle starts to slip but before the patient feels it, a deliberately narrow window. Welcome to aortic regurgitation. Before we touch mechanisms or management, this first section lays the foundations, and it is worth getting them rock solid because everything downstream depends on them. We will start by defining exactly what regurgitation is: blood leaking backwards across a valve that should be one way, and the haemodynamic burden that places on the heart. Then comes the single most important organizing idea in the whole topic: the divide between acute and chronic disease. It is genuinely one lesion behaving as two entirely different illnesses depending on how fast it arrives. And if you hold that distinction firmly, the clinical features, the investigations, and the treatment all fall into place. Keep asking yourself throughout: is this the slow leak or the sudden one? Let us nail the definition, because the words do real work. Aortic regurgitation is simply a valve that does not seal in diastole, so blood the ventricle just ejected sloshes back in. The immediate consequence is that total stroke volume goes up. On each beat, the ventricle has to pump the blood that actually leaves the body forward, plus the portion that will leak back. In severe disease, those two can be equal, so the ventricle does double duty to achieve a normal output. Think of bailing a boat while someone pours the bucket back in. Here is the contrast that makes AR mechanically nastier than mitral regurgitation. A leaking mitral valve empties into the low pressure left atrium, but the regurgitant aortic valve still has to eject the whole load into a high pressure aorta. Same word, regurgitation, very different afterload. Hold on to the idea that the fault lives in one of three places: leaflets, root, or both, because that is exactly how we will organize the causes in a moment. If you remember one slide from the foundations, make it this one. The lesion, a leaky aortic valve, can be identical, yet acute and chronic AR are almost different diseases, and the variable is time. Give the ventricle years and it remodels. It dilates and adds muscle so it can hold a big regurgitant volume at a comfortable filling pressure. That patient can stroll around symptom free for a decade with dramatic bounding pulses and a long blowing murmur. Now take the same volume of leak and inflict it overnight. Say endocarditis perforates a cusp or a dissection wrecks the root. The ventricle is normal sized and stiff. It cannot stretch in time, so end diastolic pressure shoots up, sometimes past 40, slamming the mitral valve shut early and backing pressure into the lungs. There are almost no bounding pulses to warn you, just a tachycardic, breathless, crashing patient. The trap is obvious. The acute case is the emergency that looks least like the textbook AR you were taught to spot. A short epidemiology slide, but with a careful edge. The one firm number Harrison gives is the sex distribution. Roughly 3 out of 4 patients with pure or predominant valvular AR are men. There is a neat exception that examiners love. When AR travels together with rheumatic mitral valve disease, the balance flips and women predominate. So, if you are told the patient is a woman with mixed mitral and aortic disease, rheumatic etiology should light up in your mind. Beyond sex, the cause of AR tracks age and geography. In younger Western populations, you think bicuspid valves and aortic root disease, whereas rheumatic heart disease still dominates across much of the world. Now we turn to causes, and I promise this section is far less daunting than the long list in most textbooks because there is a trick. Every single cause of aortic regurgitation does its damage in one of just two places. It either wrecks the valve leaflets themselves or it stretches the aortic root so wide that perfectly good leaflets can no longer meet door or door frame. Sort every cause into those two buckets, and the list stops being rote memorization and becomes a logical framework. We will populate each bucket in turn, then overlay the acute versus chronic divide, which causes ambush the patient in hours and which simmer over years, and finish with the signature associations that let you pattern match in an exam. Watch for the two troublemakers, bicuspid disease and syphilis, that cunningly sit in both buckets at once. Here is a single mental model that tames the cause list. Ask one question of any regurgitant aortic valve. Is the problem the door or the door frame? Bucket 1 is leaflet disease. The door itself is thickened, perforated, retracted, or floppy, so the cusps no longer meet. Bucket 2 is root disease. The leaflets may be pristine, but the annulus has been stretched so wide that perfectly good cusps simply cannot reach each other. That second idea catches people out. You can have severe AR with structurally normal leaflets purely because of geometry. Then, to keep you humble, two culprits straddle both buckets: the bicuspid valve, which is an abnormal leaflet that also comes with an aortopathy, and syphilis, which scars leaflet and aorta together. And remember the feedback loop. A long standing leaflet problem can secondarily widen the annulus, blurring the line. Sort first, then memorize within each bucket. It is far less to hold in your head. These are the leaflet causes, and a few deserve a spotlight. The bicuspid valve is the one you will meet most. It is the commonest congenital valve abnormality, and around a fifth of these patients come to aortic valve surgery somewhere between 10 and 40 years of age, often for regurgitation rather than stenosis. Endocarditis is the classic acute destroyer. A vegetation eats through a cusp and the valve fails overnight. Rheumatic disease almost never attacks the aortic valve alone. If the aortic and mitral valves are both involved, rheumatic etiology should be at the top of your list. A lovely exam fact lives in the ventricular septal defect line. A cusp can prolapse into the defect and roughly 15% develop chronic AR. And the trauma line is a genuine pearl. In someone who survived a steering wheel chest impact, a torn aortic cusp is the single most frequent serious valvular injury. Syphilis and ankylosing spondylitis scar the leaflet, but they usually bring root disease along too, which bridges us to the next slide. Now, the root causes, the leaflets here are often blameless. The unifying idea is geometry: dilate the annulus enough, and even normal cusps cannot coapt, so blood leaks. Aortic dissection is the dramatic acute member. A type A dissection peels back into the annulus and produces sudden severe AR on top of a catastrophe. Marfan is the textbook chronic one. Beautiful, normal looking leaflets that simply cannot span a balloon route. Notice that the bicuspid valve reappears here. It is the great double agent, an abnormal leaflet that also carries an aortopathy, which is exactly why bicuspid patients need their aorta watched, not just their valve. Non-syndromic familial aneurysms and the aortitis, Takayasu and Jansel dilate by different routes to the same end. And two slow burners. Severe long-standing hypertension can widen the annulus, while syphilitic aortitis, once common, now a rarity, scars the aortic media. The takeaway for the clinic is that root AR means you must image the whole aorta because the valve is only half the story. Same cause list, resorted by tempo, because tempo decides whether your patient walks into clinic or crashes into resus. The acute ambushers are a short high-yield trio: endocarditis perforating a cusp, a type A dissection tearing into the annulus, and chest trauma avulsing a leaflet. Prosthetic valve dehiscence belongs here too, though verify the specifics for your case. What unites them is that the ventricle gets no warning. A stiff, normal-sized chamber meets a sudden flood, filling pressure rockets, and the lungs drown. The chronic simmerers are the ones that grant a long latent period: bicuspid disease in the young Westerner, rheumatic disease worldwide, myxomatous prolapse, and the whole family of root diseases from Marfan to hypertension. Here, the ventricle has years to remodel, so the patient banks a decade or more of feeling well. Clinically, the lesson is that the cause tells you the clock speed, and the clock speed tells you whether you have minutes or years. Examiners adore association questions because they test whether you can move from a clue to a cause in one step. So let us drill the highest yield links. See, a bicuspid valve, and you should immediately think two things: a real chance of valve surgery in early to mid adult life, and an aorta that needs surveillance. See a ventricular septal defect and a new diastolic murmur and a prolapsing cusp around 15% should spring to mind. The combination of genuinely significant stenosis and regurgitation in the same valve is a powerful discriminator. It points almost exclusively to rheumatic or congenital disease and lets you cross off the exotic causes. In a survivor of blunt chest trauma, the aortic valve is the structure most likely to have been seriously injured. The triad of Marfan, ankylosing spondylitis, and syphilis should trigger root imaging because the AR is geometry driven. And keep one humble caveat in mind. A primary leaflet problem can, over years, stretch the annulus and manufacture a root problem on top. The buckets leak into each other. This is the engine room of the whole topic. Aortic regurgitation is special among valve lesions because it imposes two burdens on the ventricle at the same time. A volume overload because all the leaked blood must be pumped again, and a pressure overload because that large stroke volume drives a high systolic pressure. That dual hit explains everything we will see clinically: the enormous heart, sometimes over a kilogram, the remarkable decade of silence while the ventricle compensates, and the eventual, often sudden, decline. We will build it step by step. The combined overload, the elegant compensation through eccentric hypertrophy, the treacherous point where compensation fails silently before symptoms appear, and the special case of acute disease. Understand this section and you will never again have to memorize a clinical sign. You will simply derive it from the physiology. This is the keystone slide, so let us go slowly. Start at the top. Severe AR forces the ventricle to handle a bigger total stroke volume on every beat, because it must move the forward output plus the leak. That extra filling raises end diastolic volume, that is the volume overload arm shown in teal, and it is exactly what mitral regurgitation does too. But AR adds a second arm that mitral regurgitation does not. As the chamber dilates, Laplace's law kicks in. Wall tension rises in proportion to radius, so the ventricle now faces higher afterload to generate the same pressure, the pressure overload arm in crimson, the kind of burden you normally associate with aortic stenosis. Put the two arms together and you get the defining statement of the disease. AR is simultaneously a volume and a pressure overload, and the ventricle answers with eccentric hypertrophy and dilation. The comparison strip is worth memorizing verbatim. Mitral regurgitation is volume only, stenosis is pressure only, and AR is the one lesion that is both, which is precisely why its ventricle eventually grows enormous and then gives out. Given that AR is such a heavy dual load, why can patients feel perfectly well for a decade or more? Because the ventricle is a superb adapter and it uses two tricks. First, Frank Starling, a bigger end diastolic volume, stretches the muscle and recruits more forceful contraction. Second, eccentric hypertrophy. The heart lays down new sarcomeres in series, so the cavity enlarges and each individual fiber still only has to shorten by its normal amount to eject a much larger stroke volume. The result is genuinely elegant. A huge total stroke volume leaves the ventricle, the forward output stays normal, and the ejection fraction reads normal. So a casual look is reassured. But notice the hidden cost on the right. The end diastolic volume and pressure are already elevated, and every increment of dilation raises wall tension through Laplace. So afterload is creeping up in the background. That is the compensated paradox in the gold box, and it is the reason you cannot relax just because today's ejection fraction looks fine. The trouble is being hidden, not avoided. This slide answers a question students often ask. If both mitral and aortic regurgitation are leaks, why is AR mechanically the tougher load? The answer is the destination of the leak. A regurgitant mitral valve decompresses the ventricle into the low pressure left atrium. It is a pop-off valve, so although it is a volume overload, the afterload stays modest. The regurgitant aortic valve gives no such relief. The ventricle still has to eject its entire stroke volume into the high pressure aorta and then watch a chunk of it leak back in. So AR layers a pressure overload on top of the volume overload, while mitral regurgitation is essentially volume alone. The little table crystallizes the trio for exams. Mitral regurgitation is volume only, aortic stenosis is pressure only, and aortic regurgitation is the one that is both, dumping into a high pressure chamber. If you can reproduce that grid under pressure, you have understood the single most testable hemodynamic idea in the whole topic. Compensation is brilliant, but it is not infinite. And this slide is about the moment it runs out and the trap hidden in that moment. As the years pass, the adaptive machinery is overwhelmed. End diastolic volume keeps rising, and now the forward stroke volume and the ejection fraction begin to slide. Look at the curve. The ejection fraction holds up beautifully, then it starts to fall, and crucially, symptoms do not arrive at the same time. They lag behind, which creates the shaded silent gap, a stretch of disease where the ventricle is measurably deteriorating but the patient still feels completely well. That single fact, dysfunction precedes symptoms, is the reason we cannot wait for patients to complain. We have to go looking with serial echocardiography. And if we ignore it for long enough, we get the pathological endpoint on the right. The cor bovinum, the ox heart, a ventricle that at autopsy can top 1,000 grams, among the largest human hearts ever weighed. The whole art of timing surgery, which we reach later, lives inside that gold band. Acute AR is a different animal hemodynamically, and this pressure picture explains why it is so dangerous and so easy to underestimate. The ventricle has had no time to dilate, so it is a normal sized, relatively stiff chamber suddenly asked to swallow a large regurgitant volume in diastole. With nowhere to put it, the LV diastolic pressure climbs steeply, the crimson curve, sometimes past 40 millimeters of mercury. Follow it until it crosses the gently rising left atrial pressure, the T line. At that crossing point, something important happens. The ventricle is now at higher pressure than the atrium while still in diastole, so the mitral valve is pushed shut early. That premature mitral closure is partly protective. It shields the pulmonary capillaries from the soaring ventricular pressure, but it also softens the first heart sound and strips away the bounding pulses. So the patient who most needs urgent recognition is the one whose examination looks least dramatic. Meanwhile, forward output falls and the lungs flood. This is a surgical emergency measured in hours. Here is a fact that surprises patients and juniors alike. Someone with severe AR can have crushing angina and pristine coronary arteries. The slide shows why as a tug of war. On the demand side, in crimson, everything is pushing oxygen consumption up. The ventricle is large, so wall radius is big. It is thick with eccentric hypertrophy, so there is more muscle to feed. And Laplace means the wall tension it must generate is high. On the supply side, in teal, the deck is stacked against the heart. Most coronary perfusion happens in diastole, but in AR, the aortic diastolic pressure is precisely what collapses. Those wide pulse pressures we love at the bedside mean a low diastolic number, so the very pressure that drives blood into the coronaries is reduced. High demand meeting low supply lands hardest on the subendocardium, the most vulnerable layer, and you get true ischemia without a single plaque. Two clinical fingerprints worth remembering. The angina can strike young patients and at night, and it responds poorly to sublingual nitroglycerin, unlike the angina of coronary disease. Let us close the mechanism section by tying hemodynamics straight to the stethoscope, because this is where understanding pays off in the exam. The engine of the leak is the reverse pressure gradient between the aorta and the left ventricle in diastole. Blood flows backward only because aortic pressure exceeds ventricular pressure. Now watch the two curves. At the very start of diastole, the gap between them is widest. Aortic pressure is still high and ventricular pressure is still low, so the gradient is maximal and the leak and the murmur is loudest. As diastole continues, aortic pressure falls and ventricular pressure rises, so the gap narrows, the driving force fades, and the sound tapers away. Map that shrinking gradient onto sound, and you get exactly the murmur we hear, a high-pitched, blowing, decrescendo early diastolic murmur, which lengthens to fill diastole as severity increases. One elegant corollary in the flag: in chronic severe AR with a slow heart rate, the two pressures may actually equalize before diastole ends the gradient, and the murmur can run out before the next beat begins. Having understood the physiology, we now need to classify, because classification is how raw understanding becomes clinical decisions. Three jobs in this section. First, we formally separate acute from chronic disease, the divide we keep returning to, and lay their features side by side, because the speed of onset, not the cause, decides whether the ventricle copes. Second, we grade severity on the echocardiogram, the vena contracta, jet width, regurgitant volume and fraction, and the wonderfully reliable sign of hollow diastolic flow reversal, and the descending aorta. Third, and most practically, we place each patient on the stage ladder from A to D, because those stages carry the exact trigger points that send someone to surgery. Think of this section as building the ruler we will use for the rest of the lecture, a way to say precisely how bad is bad and when bad becomes actionable. If you remember one organizing principle for this whole topic, make it this table. The same incompetent valve produces two completely different diseases, depending only on how fast it arrives. Run your eye down the acute column: a normal size stiff ventricle, pressures that rocket, a near normal pulse pressure that hides the diagnosis, and a patient crashing into pulmonary edema within hours. Now the chronic column. Years of slow dilation give a big compliant ventricle that swallows an enormous regurgitant volume, generates those flamboyant bounding pulses, and stays comfortable for a decade. The trap for the unwary is that acute severe AR looks deceptively unimpressive at the bedside. Soft murmur, modest pulses, precisely because the ventricle has not had time to remodel. Same lesion, opposite examination, opposite urgency. Sort by tempo first, and everything else falls into place. Grading aortic regurgitation is a composite sport, not a single measurement, and the examiners know it. The table lists the quantitative thresholds that define severe disease. A color jet filling more than about two-thirds of the outflow tract. A vena contracta wider than 6 millimeters. A regurgitant volume of 60 millimeters or more. A regurgitant fraction of at least a half, and an effective orifice of 3/10 of a square centimeter or greater. My favorite, because it is robust and easy to teach, is hollow diastolic flow reversal in the proximal descending aorta. If blood is running backwards down the aorta throughout diastole, the leak is hemodynamically serious. The teal box is the real examination point. Never hang the diagnosis on one parameter. Pool the measures, sanity check them against image quality and the clinical picture. And remember that in acute AR, the pressure half time shortens dramatically as ventricular and aortic pressures equalize fast. The stage ladder is how modern guidelines turn a spectrum into decisions, and it climbs from left to right. Stage A is the at-risk patient, a bicuspid valve or a dilated aorta with no meaningful leak yet. You are watching, not treating. Stage B is progressive disease, mild to moderate regurgitation with a ventricle that is still normal. Stage C is the pivotal one. Severe regurgitation but no symptoms, and it splits in two. C1 keeps a normal ventricle, while C2 is the silent decompensation we worry about. The ejection fraction has slipped to 55% or below, or the end systolic dimension has crossed 50 millimeters. That C1 to C2 transition is exactly when asymptomatic patients earn an operation. Stage D is symptomatic severe disease. Notice the engine of decision making. We do not wait for symptoms in severe AR. A failing ventricle on the scan is reason enough to act. Always confirm the precise numbers against the version of the guideline in front of you. This is the bedside section, and it is where aortic regurgitation becomes genuinely fun to examine because few conditions reward a careful clinician so richly. We will trace the clinical story in three movements. First, the natural history, that long, eerie silence of chronic disease, and then the symptoms that finally break it: breathlessness, the characteristic angina with normal coronaries, and the ominous acute crash. Second, the flamboyant signs of a hyperdynamic circulation, all of the famous eponyms, which I will show you, flow from a single number. The white pulse pressure. Master that one idea and you get Corrigan, Quink, Demusset, and the rest for free. Third, we put hand and stethoscope on the chest, the displaced heaving apex and the murmurs that clinch it. Throughout, hold on to the acute versus chronic contrast because in acute disease, all this drama vanishes, and that absence is itself the warning. Chronic aortic regurgitation is a master of disguise, and its defining clinical feature is how little the patient feels for how long. The timeline says it all: a decade or more of silence. The reason sits in the left box. Eccentric hypertrophy lets the ventricle enlarge and keep forward stroke volume normal at rest. And because the remodeling is slow and adaptive, there is never a dramatic moment the patient can point to. The cruel corollary is that symptoms may not appear until compensation is already failing. So, what are the first whispers in the gold box? Not breathlessness, interestingly, but an uncomfortable awareness of the heartbeat, pounding in the head and neck that is worse lying flat, and palpitations that jump with every ectopic beat. These are not heart failure, they are simply the large stroke volume and those bounding pulses being felt. Reassure the mechanism but mark the calendar, the silence is ending. Once the ventricle can no longer keep up, symptoms arrive in a fairly predictable order, and knowing that order scores marks. The first thing to fail is reserve, so the earliest complaint is breathlessness on exertion. As filling pressures climb, that progresses to orthopnoea, paroxysmal nocturnal dyspnea, and uncomfortable sweating. Then comes one of the most testable features in all of cardiology: angina in a patient with completely normal coronary arteries. It is classically nocturnal and it responds poorly to sublingual nitroglycerin, two clues that separate it from ordinary coronary angina. Why nocturnal? Because the heart rate slows in sleep, diastole lengthens, aortic diastolic pressure falls even lower, And subendocardial perfusion suffers most just when you would expect rest to help. Finally, the right heart is dragged in and you see hepatic congestion and ankle swelling. The headline for the exam and the clinic is simple. The appearance of symptoms is an ominous turning point that pushes the conversation firmly towards surgery. Acute aortic regurgitation does not read the chronic textbook, and its presentation can kill the unwary. Follow the crimson cascade on the left. A normal sized, relatively stiff ventricle is suddenly handed an enormous leak with no time to dilate. Its diastolic pressure soars within hours. That pressure backs straight up into the lungs, giving flash pulmonary oedema, and forward output falls off a cliff into cardiogenic shock. Now, the part that catches people out in the gold box, the bedside examination looks deceptively bland. The murmur is soft and short, the pulses are nearly normal, none of the flamboyant chronic signs are present, precisely because the ventricle has not remodeled. A sick patient with an unimpressive heart examination is the trap. Whenever you meet acute severe AR, two diagnoses should leap to mind: aortic dissection and infective endocarditis. Image the aorta, take blood cultures, and get the patient in front of a surgeon. This is measured in hours, not days. Almost every famous peripheral sign in aortic regurgitation flows from one number, a wide pulse pressure. Look at the bars. In chronic severe AR, the ventricle ejects its normal forward output plus the large volume that leaked back, so the systolic pressure is driven high, here around 160. Then, during diastole, that same blood runs backwards into the ventricle and also off into a dilated periphery, so the diastolic pressure falls low, maybe 50. Subtract one from the other, and the pulse pressure is enormous, perhaps 110 against a normal 40. That single widened gap is the hydraulic engine behind the bounding, collapsing water hammer pulse and all the eponyms we are about to meet. Teach it as cause and effect: high systolic from a big stroke volume, low diastolic from rapid runoff, and a pulse that leaps up and drops away. Understand the number, and you never have to memorize the signs as a disconnected list again. Here is a bedside roll call, and the secret to remembering it is that these are not 7 unrelated party tricks, they are 7 windows onto the same wide pulse pressure. Corrigans, the water hammer pulse is the headline. A forceful upstroke that collapses just as quickly. Demoset noticed his patient's heads nodding in time with the heartbeat. Quinker pressed a nail bed and watched the capillaries pulse. Traube heard a pistol shot crack over the femoral artery, and Durouzier turned that into a to and fro bruit by gently compressing it. The Bispherian's pulse, with its 2 systolic peaks, is felt best when stenosis keeps the valve company. Even the uvula joins in. Muller's sign. They make marvelous eponym questions, but here is the clinical sting in the tail. Because they all depend on a wide pulse pressure, they are conspicuously absent in acute severe AR. A desperately unwell patient with quiet pulses is a red flag, not reassurance. Put your fingers on the pulse and let the waveform tell the story. The teal trace on the left is normal, a smooth rise, a rounded summit, and a gentle descent interrupted by the dicrotic notch. The crimson trace in the middle is the one that matters in aortic regurgitation, the Corrigan or water hammer pulse. The large stroke volume throws the pressure up steeply to a sharp peak, and then the rapid runoff, half of it leaking back into the ventricle, lets it collapse just as abruptly. Rises fast, falls fast, that is the whole gestalt. The gold trace on the right is the Bispherian's pulse, with 2 systolic peaks in a single beat. You feel it most clearly when the valve is both leaking and stenosed, so it is a useful hint that mixed disease is present. A neat way to lock it in: lift a patient's arm, and the bounding Corrigan pulse often becomes even more obvious as runoff increases. Before the stethoscope, let your palm do some diagnosis. 3 findings sit on the precordium. First, the apex beat. In chronic AR, the dilated volume-loaded ventricle pushes it down and out to the left, and it feels diffuse and heaving rather than a neat tap. That lateral displacement is one of the better bedside guides to ventricular enlargement. Second, run your hand up the left sternal border with the patient sitting forward in held expiration. A loud regurgitant murmur can be palpable as a diastolic thrill. Third, at the suprasternal notch and over the carotids, you may feel a systolic thrill. Do not overcall aortic stenosis from this alone, because the sheer size of the stroke volume crossing a normal sized orifice generates turbulence by itself. So, a heaving displaced apex tells you the ventricle is big, a diastolic thrill tells you the leak is loud, and a systolic thrill tells you a lot of blood is moving fast. Hands first, then ears. This is the murmur. that wins or loses bedside cases, so let us be precise. It is an early diastolic murmur. It begins immediately after the second heart sound, and it is high pitched, blowing and decrescendo because, as we saw, the driving gradient is loudest at the start of diastole and fades as pressures equalize. To hear it, use the diaphragm at the third left intercostal space, Erb's point, with the patient sitting forward and holding the breath out. A quick squeeze of your hands, a hand grip raises after load and makes it louder. Two genuinely high yield pearls. First, location reveals cause. A murmur loudest down the left sternal border points to leaflet disease, whereas one loudest down the right sternal edge points to a dilated aortic root. Second, in severe regurgitation, the aortic component of the second sound goes soft or vanishes because the cusps are no longer slam shut, and a musical cooing quality hints that a cusp has everted or perforated. Aortic regurgitation rarely travels alone on a US auscultation. Two companion murmurs turn up, and each is a classic trap. On the left is the Austin Flint murmur, a soft, low-pitched, rumbling sound in mid to late diastole that sounds uncannily like mitral stenosis. The mechanism is elegant. The regurgitant jet from the aortic valve strikes the anterior mitral leaflet and effectively narrows the mitral inflow, generating the rumble without any structural mitral disease. The discriminators are crucial for the exam. There is no opening snap and no loud first heart sound, both of which you would expect in genuine mitral stenosis. On the right is a mid-systolic ejection murmur. Here the explanation is simply flow. An enormous stroke volume crossing even a normal aortic valve makes turbulence and noise during systole. It is common in significant AR and does not on its own mean the valve is stenosed. Two extra murmurs, two opportunities to overdiagnose, and now you won't. Let us close the examination section with the single most dangerous mismatch in valve disease. Everything flamboyant about chronic AR, the long blowing murmur, the bounding pulses, the wide pulse pressure evaporates when the leak is acute. Look at the phonogram. The first heart sound is soft because the ventricular pressure rises so fast that the mitral valve is pushed shut prematurely before systole has even started. The diastolic murmur is short and soft because the stiff ventricle's pressure climbs to meet aortic diastolic pressure almost immediately, so the driving gradient lasts only a moment. The pulse pressure is unremarkable because there has been no time to dilate, so Corrigan and his friends never put that together. And you have a patient who is tachycardic, hypotensive, and frankly unwell, yet whose heart sounds are deceptively quiet. The lesson in the gold box is one to carry for life. In acute AR, the bedside understates the catastrophe. If the patient is crashing and the heart sounds are soft, get an urgent echocardiogram. With the diagnosis suspected at the bedside, we now confirm and quantify it, and this section is organized by a simple hierarchy of value. We will glance first at the cheap ubiquitous test, the electrocardiogram, which shows left ventricular hypertrophy with a strain pattern, and the chest radiograph, while being honest that neither confirms nor grades the leak. Then we arrive at the star of the show, echocardiography, the diagnostic cornerstone, which in a single sitting tells us whether it is regurgitation, how severe, why it is leaking, how the ventricle is coping, and how wide the aorta is. Finally, we cover the advanced tools, transesophageal echo, cardiac MRI, Connecticut, and catheterization, each reserved for a specific question the standard scan cannot answer. The recurring theme is proportion. Use the right test for the right question and let the echocardiogram do the heavy lifting. The electrocardiogram in chronic aortic regurgitation is a supporting actor, not the lead, but it tells a coherent story. Because the ventricle is dilated and working hard, you see the voltage criteria of left ventricular hypertrophy, and overlaid on that is the so-called strain pattern, downsloping ST depression, and T-wave inversion in the lateral leads, that is leads 1, AVL, V5, and V6. As the ventricle enlarges, the axis often swings to the left, and later in the disease, when conduction tissue becomes involved, the QRS may widen. Here is the examiner pleasing caveat in the gold box. None of this confirms aortic regurgitation, and none of it grades severity. A perfectly normal ECG does not exclude significant AR, and florid LVH does not quantify the leak. Treat the trace as a barometer of ventricular burden over time, useful on serial follow-up, while the echocardiogram does the real diagnostic heavy lifting. If you take one investigation into the exam, make it the transthoracic echocardiogram because it answers every question that matters in a single sitting. First, is this really aortic regurgitation, and how bad is it? Color Doppler shows the jet and the quantitative tools, vena contracta, jet width relative to the outflow tract, regurgitant volume and fraction, and effective orifice area, grade it. Second, why is it leaking? You can see directly whether the problem is the leaflets or a dilated root, which is exactly the two bucket framework from earlier made visible. Third, and crucially for management, how is the left ventricle? Its size and ejection fraction are the very numbers that trigger surgery. Fourth, how wide is the aorta, which you must know in bicuspid and Marfan patients. And finally, is the anatomy suitable for a valve sparing repair? One non invasive test, five decisive answers. That is why echo is the cornerstone. Beyond grading the leak, the echo offers two more gifts. The teal box is the modern, high yield one, global longitudinal strain. Using speckle tracking strain imaging can reveal that the ventricle's contractility is already slipping while the ejection fraction still reads reassuringly normal. It is an early warning system for the silent decompensation we keep returning to, and it is increasingly used to time surgery. Pair it with three-dimensional volumes, which size the ventricle more reproducibly than two-dimensional measurements, and you can track subtle change reliably over the years. The crimson box holds the classic signs that make lovely exam questions. Find diastolic fluttering of the anterior mitral leaflet, which is the actual mechanism behind the Austin Flint murmur. A rapid deceleration of the continuous wave signal, meaning a short pressure half time, which flags acute or severe disease, progressive ventricular dilation, and most ominously, premature mitral closure in the acute setting. Old signs and new tools working together. When the transthoracic study leaves questions, three advanced tools step in, each with a niche worth knowing. Transosophageal echo on the left sits right behind the heart and gives exquisite views of the leaflets and root. It is the tool that helps the surgeon decide whether a valve can be repaired rather than replaced, and it checks the result on the table. Cardiac MRI in the middle is the reference standard. When echo windows are poor, it measures ventricular volumes and ejection fraction reproducibly, quantifies the regurgitant volume and fraction directly, and increasingly importantly, reveals myocardial fibrosis on late gadolinium imaging and extracellular volume mapping, which carries prognostic weight. Computed tomography on the right maps the valve, root, and the entire thoracic aorta, so it is indispensable for aneurysmic surveillance and for sizing transcatheter procedures, and it can clear the coronaries before surgery in selected patients. Echo first, then pick the tool that answers the specific question. The chest radiograph is cheap, quick, and frequently the first image you see, so know what it can and cannot do. In long-standing chronic AR, the volume-loaded ventricle enlarges the cardiac silhouette and pushes the apex down and out, giving that classic boot shape, and you may spot a dilated ascending aorta or a prominent aortic knuckle, which is a handy pointer towards root disease. If filling pressures have risen or if the regurgitation is acute, the lungs show congestion. But here is the caveat that earns marks and saves patients in the gold box. The film is both insensitive and non-specific. Most damningly, in acute severe AR, the heart has had no time to dilate, so the cardiac silhouette can look entirely normal even while the patient is drowning in pulmonary edema. So use the chest film as a first glance and a clue to chamber and aortic size, but never let a normal looking film talk you out of a diagnosis the echo would confirm in seconds. Two targeted tests round out the workup, each answering a specific question rather than screening blindly. Cardiac catheterization on the left has been quietly demoted by echo and MRI, but it keeps a clear role. Before any aortic valve operation, you generally need to know the state of the coronary arteries. So, coronary angiography is routine in patients with risk factors or of older age. When the non-invasive grade is genuinely uncertain or the tests disagree, aortography can grade the leak and direct pressure measurement can pin down ventricular filling pressures. On the right is exercise testing, which earns its place mainly to call the bluff of the supposedly asymptomatic patient. Severe AR with a normal ventricle but a poor exercise tolerance is not truly asymptomatic, and an objective drop in capacity can tip an equivocal case towards surgery. Stress echo may even expose a contractile reserve deficit hidden at rest. One rule for safety: do not exercise test the overtly symptomatic patient. They already qualify for an operation. A short but high yield section, because aortic regurgitation has a handful of convincing imposters and examiners adore them. The confusion clusters around two sounds. The first is the early diastolic murmur. Ours is high pitched, blowing and decrescendo, but so is the Graham Steele murmur of pulmonary regurgitation, and we will learn the two discriminators, respiration and the pulse pressure, that reliably separate them. Second is the diastolic rumble. An Austin Flint murmur can masquerade as genuine mitral stenosis, and the elegant amyl nitrite maneuver tells them apart by pushing the two murmurs in opposite directions. Finally, because a bounding pulse is not unique to aortic regurgitation, We will run through the other causes of a wide pulse pressure, the high output and runoff states. The lesson of the whole section is humility. Hear the murmur, then look hard at the company it keeps before you commit. Both of these are high-pitched, blowing, decrescendo murmurs that begin right after the second heart sound. So on quality alone, they are genuinely hard to separate, which is exactly why examiners love them. The Graham-Steele murmur is pulmonary regurgitation, and it appears when pulmonary hypertension, classically from mitral stenosis, dilates the pulmonary valve annulus. Two discriminators do most of the work. First, respiration. Right-sided murmurs, including pulmonary regurgitation, get louder as you breathe in, whereas the left-sided aortic murmur is louder in expiration. Second, and even more reliable, the pulse pressure. Aortic regurgitation throws a wide bounding pulse with all its peripheral eponyms, while pulmonary regurgitation leaves the pulse entirely normal. Then look at the company the murmur keeps. Signs of pulmonary hypertension. A loud P2 and a right ventricular heave point to Graham-Steele, whereas peripheral arterial signs point to aortic disease. Respiration and the pulse. Get those two and you will rarely be wrong. Two more traps and they are favorites. On the left, an Austin Flint murmur can be mistaken for genuine mitral stenosis because both rumble in diastole. The discriminators are clean. True mitral stenosis gives a loud slapping first heart sound and an opening snap, neither of which the Austin Flint murmur produces. The most elegant bedside test is amyl nitrite, a vasodilator that drops after load. It reduces the aortic regurgitant volume so an Austin Flint murmur gets quieter, but it increases flow across the mitral valve so a true stenotic rumble gets louder. Opposite responses, one sniff. On the right is the broader differential for the wide bounding pulse because aortic regurgitation is not its only cause. High output and runoff states do the same thing. Anemia, thyrotoxicosis, and arteriovenous fistula, beriberi, Paget's disease, pregnancy and fever, plus the patent ductus arteriosus, which adds its own continuous machinery murmur. Find a bounding pulse, then look for the aortic murmur and the company it keeps before you commit to AR. This is the longest and arguably most important section because management is where all the preceding understanding pays off in decisions that change lives. Start from one blunt truth. The leak is a mechanical problem, so the definitive fix is mechanical surgery. Drugs only ever buy time or rescue the acute crisis. We will split care along the familiar fault line. The acute emergency with its two classic don'ts versus the chronic planned pathway. Then we will be honest about medical therapy and its real limits. The heart of the section is timing, the two governing principles and the precise ejection fraction and dimension triggers that decide when to operate, followed by the formal indication tables and a clean decision algorithm. Finally, we will tour the operations themselves, from replacement to elegant valve sparing repair, and explain why transcatheter valves struggle here. The whole art, remember, lies in catching the surgical window before the ventricle is damaged beyond recovery. Before the details fix the big picture. Aortic regurgitation walks through your door as one of two completely different patients, and they go down opposite pathways. On the left is acute severe AR, think dissection, endocarditis, or trauma, which is a hemodynamic emergency measured in hours. Here, medicine only buys minutes. Intravenous vasodilators, sometimes inotropes as a bridge, while you get the patient to theatre, usually within a day. Two things to actively avoid, which we will justify shortly, are the intra-aortic balloon pump and beta blockers. On the right is chronic severe AR, the watchful waiting patient. If they are asymptomatic with a normal ventricle, you survey them with echocardiography every 6 to 12 months and treat any hypertension. You intervene only when a trigger is crossed, the onset of symptoms, or a ventricle that is starting to fail or dilate. Both roads ultimately lead to surgery. Because the lesion is mechanical, the difference is entirely one of tempo and timing. Acute severe AR is where calm, correct reflexes save lives, and it contains two of the most testable don'ts in cardiology. On the do side, lower the afterload with intravenous sodium nitroprusside so that more blood goes forwards instead of backwards. Unload the flooded lungs with diuretics. Support the circulation with inotropes if needed and treat the underlying cause, antibiotics for endocarditis, pressure and rate control for dissection. But all of that is merely a bridge. The definitive treatment is surgery, usually within 24 hours. Now, the traps. First, the intra-aortic balloon pump is contraindicated because it inflates during diastole and would pump yet more blood backwards through the incompetent valve. Second, resist the urge to slow a fast heart. In acute AR, the tachycardia is protective, shortening diastole and so limiting the time available for regurgitation, which means beta blockers can make things worse. The one nuance is dissection, where you still need careful rate control, a deliberate balancing act. Here is where you must be honest with yourself and with the examiner. In chronic aortic regurgitation, medical therapy is supportive, not disease modifying. The banner says it plainly. No drug reliably prolongs the asymptomatic phase or postpones the operation in a patient whose blood pressure is normal. So, what is worth doing? Treat hypertension when the systolic pressure climbs above about 140 using an ACE inhibitor or ARB, a dihydropyridine calcium blocker, or hydralazine because a lower afterload genuinely helps the leak. Treat arrhythmias and infections quickly since the volume loaded ventricle tolerates them badly, and you may trial nitrates for angina even though they work less well than in coronary disease. What not to do? Do not lean on vasodilators to defer surgery in normotensive patients. Do not let a patient with a dilated aorta strain against heavy weights. And above all, do not let the comfortable phrase on medical treatment lull you into stopping your echocardiographic surveillance. The valve is still leaking. A few situations deserve tailored handling. The left card is the aorta-centered patient, Marfan syndrome, and the other heritable aortopathies. In younger patients, both beta blockers and angiotensin receptor blockers such as losartan slow the rate at which the aortic root dilates, and a well-known randomized trial directly compared atenolol with losartan and found them essentially equivalent, so there is no clear winner, either is reasonable. Crucially, in these patients, you watch the aorta with serial imaging and operate on it at size thresholds, not merely when the valve leaks. The right card holds a satisfying rarity. Syphilitic aortitis is a cause you can genuinely treat with the full course of penicillin for the underlying disease. Though remember that antibiotics address the infection, not a valve that is already incompetent, which still needs surgery. And for bicuspid and familial thoracic aortic disease, think like a geneticist. Screen first degree relatives, image the entire thoracic aorta, and control the blood pressure, because here the aortopathy, not just the valve, writes the prognosis. All of surgical timing in aortic regurgitation hangs on two principles, and if you internalize them, the indication tables almost write themselves. Principle 1: symptoms arrive late. Because the ventricle compensates so well for so long, most patients do not become symptomatic until myocardial dysfunction has already started, which means waiting for breathlessness or angina is waiting too long. Principle 2: delay is punished. If you let more than about a year pass after symptoms or measurable dysfunction appear, an operation frequently fails to return the ventricle to normal size and function. The damage sets. Put those together, and the practical implication in the gold box follows inexorably. You must track the ventricle objectively with clinical review and echocardiography every 6 to 12 months and act on falling ejection fraction or rising dimensions rather than on symptoms alone. The numerical triggers in the guidelines exist precisely to catch that narrow window before the harm becomes irreversible. And even when you have arrived late, a new valve usually still beats the alternate. This is the slide to photograph. The class 1 indications, the strong ones, are 3. Any symptomatic patient with severe AR earns a new valve regardless of ejection fraction because symptoms mark a ventricle already in trouble. Any asymptomatic patient whose ejection fraction has fallen to 55% or below qualifies, that being stage C2. And anyone with severe AR already going under for other cardiac surgery should have the valve dealt with at the same time. Step down to class IA, the asymptomatic patient with a still normal ejection fraction but a severely dilated ventricle, an end systolic dimension beyond 50 millimeters. Class TIB covers carefully selected earlier intervention. Progressive disease with an ejection fraction in the mid to high 50s or a very dilated end diastolic dimension in someone at low surgical risk. Finally, note why transcatheter replacement is not the answer here. In pure regurgitation, the annulus is wide and there is no calcium for the device to grip. And do verify these numbers against the latest guideline. Let us walk the whole decision as a single clean pathway because this is how it plays out in clinic. You start at the top with confirmed chronic severe aortic regurgitation. The first question is the simplest and the most powerful. Is the patient symptomatic stage D? If yes, you branch straight to valve replacement, a class 1 indication, and you are done deciding. If no, you ask the second question, which interrogates the ventricle. Has the ejection fraction fallen to 55% or below, or has the end systolic dimension exceeded 50 millimeters? If either is true, you again move to replacement class 1 or IIA depending on the exact picture. Only if both answers are reassuring, no symptoms and a preserved non-dilated ventricle, do you settle into surveillance. Clinical review and echocardiography every 6 to 12 months, treating hypertension and watching the triggers, increasingly with strain and three-dimensional volumes. Two questions, and every patient lands in the right place. The frontier of this topic is about operating at exactly the right moment, and two measurements are pushing that frontier. The first is global longitudinal strain. When the strain becomes less negative, weaker than roughly minus 18%, studies have linked it to excess mortality. And its great appeal is that it detects a ventricle starting to fail while the ejection fraction still reads normal. The second is the left ventricular end systolic volume index. At or above about 45 milliliters per square meter, it has been associated with worse event-free survival. And the principle there is that a three-dimensional volume may capture the struggling ventricle better than a single linear diameter ever could. How should you use them? As an early warning system that complements rather than replaces ejection fraction and dimensions. Ideally trended in the same lab for reproducibility, but be candid in the exam as the flag is. Much of this is single center observational evidence and the thresholds are still moving, so confirm against the current guideline before you let a strain value send someone to theatre. Finally, the operations themselves, which divide neatly into replace, repair, or spare. Replacement is the workhorse. A mechanical valve is extremely durable but commits the patient to lifelong anticoagulation, whereas a tissue valve frees them from warfarin at the cost of structural degeneration over the years. And rheumatic valves are generally too damaged to do anything but replace. The elegant middle ground is to keep the patient's own valve. In the David or valve sparing root operation shown in the placeholder, the surgeon replaces the dilated root with a fabric graft and reimplants the native valve inside it, sewing the coronary buttons back on. It is the procedure of choice when the leaflets are good but the root is aneurysmal. In acute type A dissection, roughly half of the regurgitant valves can simply be resuspended. The Ross procedure remains an option in selected younger patients. And transcatheter replacement, so transformative in stenosis, is largely stuck at the door in pure regurgitation because there is no calcium and a wide annulus, nothing for the device to grip. Having decided how and when to treat, we now ask what becomes of these patients, both if we leave the valve alone and once we have fixed it. The section has three parts. First, the complications of untreated significant regurgitation, which read like a catalog of everything the diseased ventricle eventually does: heart failure, arrhythmias, ischemia, endocarditis, and sudden death. Every one of them is, in effect, an argument for timely surgery. Second, the hard prognostic numbers, operative mortality, and how steeply it climbs once we let the ventricle deteriorate, alongside the reassurance that even late surgery usually beats the medical course. Third, the practical business of keeping patients safe between clinics, serial echocardiography, prophylaxis, where it is genuinely indicated, blood pressure control, and screening the family for inherited valve and aortic disease. The thread tying it together is that diligent surveillance and well timed intervention are what turn a grim natural history into a good outcome. If you do nothing, significant aortic regurgitation collects complications, and they map neatly onto the pathophysiology we built earlier. Heart failure is the common final pathway. The dilated, decompensated ventricle eventually cannot maintain forward output. Arrhythmias arrive, atrial fibrillation and ventricular ectopy, and the volume loaded ventricle tolerates them badly. Myocardial ischemia we have met before. That subendocardial supply demand mismatch giving angina with clean coronaries. The abnormal valve is also a standing invitation to infective endocarditis, which can itself tip chronic into acute regurgitation overnight. Most sobering is sudden cardiac death, whose risk climbs with advanced ventricular dysfunction and severe dilation, a concrete reason not to dawdle past the surgical window. And underlying all of it is progressive ventricular dysfunction, the silent complication that becomes irreversible if you miss the moment. Read this slide as a single argument. Every box is a reason to survey diligently and operate at the right time. Now, the prognostic numbers, which tell a consistent story, operate early and the risk is small, operate late and it escalates. For an otherwise healthy patient, having an isolated valve replacement for pure regurgitation, operative mortality sits at roughly 1 to 2%. Add a concomitant aortic procedure and that risk approximately doubles. But let the ventricle deteriorate first. Marked enlargement with established dysfunction, and operative mortality climbs to somewhere between 5 and 10%, with a continuing late mortality of about 3 to 5% per year thereafter. So the headline writes itself. The price of waiting is steep, which is the whole justification for those ejection fraction and dimension triggers. And yet, the second take home point matters just as much. Even a patient who arrives late with a poor ventricle usually does better with a new valve than without one. because the natural history of severe symptomatic AR on medical therapy is genuinely grim. Late is not the same as hopeless. Between operations and clinics, a handful of measures keep these patients safe, and several carry a deliberate verify flag because the exact rules shift by region and over time. The backbone is serial echocardiography. In severe disease, clinical review and a transthoracic study every 6 to 12 months, spaced out for milder leaks. Where rheumatic disease is the cause, long term penicillin prevents recurrent rheumatic fever. Endocarditis prophylaxis has narrowed dramatically over the years and is now reserved for the highest risk patients, such as those with prosthetic valves or previous endocarditis. So, check the current guideline rather than reciting an old list. Because bicuspid valves and heritable thoracic aortic disease run in families, screen first degree relatives and image their aortas, control blood pressure to spare the valve and wall. And in Marfan and bicuspid aortopathy, combine a beta blocker or ARB with scheduled aortic imaging. 6 simple habits, but confirm the prophylaxis and screening specifics against your local protocol every time. We now formalize everything we have said about timing into the 2 guidelines you are expected to know, and look honestly at the evidence still being written. The good news is that the European and American documents agree on all the big ideas: operate on the symptomatic, operate on the failing or dilating ventricle, deal with the valve during other cardiac surgery. The interest and the exam marks lie at the margins. Above all, the exact ejection fraction threshold for the asymptomatic patient, where the Europeans act a little earlier than the Americans, though both are converging around 55%. We will lay them side by side. This is the slide the postgraduate examiners love because it rewards precision. Read it as agreement on the big ideas with a few revealing differences at the edges. Both guidelines agree that any symptomatic patient with severe regurgitation should have surgery, whatever the ejection fraction. That severe regurgitation found at the time of other cardiac surgery should be fixed concurrently, and that severe left ventricular dilation is an indication. Though notice the Europeans rate the dilation trigger class 1 while the Americans rate it 2A. The single most important difference highlighted in the teal box is the ejection fraction threshold for the asymptomatic patient. The European guideline pulls the trigger at 50% as a class 1, whereas the American guideline acts at 55. The Europeans then fold 55 back in as a weaker 2B recommendation. The trajectory of both is towards intervening a little earlier, converging around an ejection fraction of 55. This is the authoritative European table for aortic regurgitation, and it is worth knowing row by row because it differs from the American one in subtle, examinable ways. The 3 class 1 recommendations are the firm ones: operate on any symptomatic patient with severe AR, whatever the ejection fraction; operate on the asymptomatic patient once the end systolic diameter passes 50 millimeters or 25 per square meter in a small person, or the ejection fraction drops to 50% or below; and deal with the valve when the patient is already having bypass or ascending aorta surgery. Then the softer recommendations, repair rather than replace, should be considered at expert centers. Note that is a 2A, the Europeans actively encourage it, and a 2B for earlier surgery, driven by a volume index above 45, an index diameter above 22, or an ejection fraction of 55. Finally, the headline novelty: transcatheter valve implantation may now be considered for the symptomatic patient who is simply too high risk for surgery if the anatomy cooperates. 3 changes pull in the same direction in ESC 2025 AS compared to 2021 towards intervening earlier and preserving the patient's own valve. First, repair has been upgraded from a tentative 2B to a confident 2A, where a durable result is expected at an experienced center. Surgeons are now told they should consider sparing the valve rather than replacing it. Second, the trigger for operating on the symptom-free patient has been both refined and strengthened. A volume index above 45 milliliters per square meter has been added alongside the diameter. The index diameter threshold has crept up from 20 to 22, and the whole recommendation now rests on level B evidence rather than expert opinion. Third, and genuinely new, transcatheter implantation has entered the regurgitation guideline for the first time, strictly for the symptomatic patient who cannot have surgery. Earlier, gentler and more personalized, that is the direction of travel. 2 frontiers are worth flagging so you sound current without overclaiming. The first, on the left, is the central unanswered question of the whole topic. In the asymptomatic patient with severe regurgitation and a still normal ventricle, is it better to operate preemptively or to watch closely and wait for a trigger? Randomized trials comparing early surgery with watchful waiting are addressing exactly this, and the result could shift the asymptomatic threshold earlier or reassure us that surveillance is safe. The honest line for the exam is that this is ongoing and there are no practice changing results to quote yet. So verify the trial's identity and status on the registry before you cite it. The second frontier on the right is transcatheter therapy for pure regurgitation, which today is hamstrung by the very anatomy we keep returning to, a soft, dilated, calcium free annulus that gives a conventional valve nothing to hold. Purpose built devices are in development, but for now, surgery remains the standard for operable patients. Sound informed, stay honest, and flag what is not yet settled. We finish where revision should, with the distal lessons. This closing section strips the whole lecture down to the rapid fire pulse most likely to earn a mark in a Viva or a single best answer question, the bedside facts, the classic traps, and the timing rules, grouped so you can drill them quickly the night before. Then we list the sources behind the deck, from Harrison's chapter to the two guidelines. As we go through the pearls, do not just memorize them. Notice how nearly everyone traces back to a principle we built earlier, the wide pulse pressure, the reverse pressure gradient, the silent decompensation, the mechanical nature of the cure. If you can reconstruct the pearl from the principle, you understand it. If you can only recite it, keep working. Let us bring it all home. Rapid fire round, the facts most likely to earn a mark. From the bedside. The wide pulse pressure is the single engine behind every eponym. So if you forget the names, reconstruct them from the physiology. Remember the side rule. A murmur loudest on the left of the sternum is a leaflet problem. On the right, a root problem. And that the second sound softens in severe disease. The traps column holds the classic discriminators: Austin Flint versus mitral stenosis, the amyl nitrite split, angina with clean coronaries, and the two acute don'ts. No balloon pump, no beta blockers. The timing column is the examiner's favorite. Operate before symptoms on objective ventricular triggers. Do not let more than a year of dysfunction elapse. Keep transcatheter valves away from operable pure regurgitation. And recall that the Marfan trial found no difference between atenolol and losartan. Learn these three columns cold, and you will handle most of what aortic regurgitation can throw at you. The core clinical content of this deck is built on Harrison's chapter with the guideline material drawn from the 2025 European and the 2020 American valvular heart disease documents